Good morning. We would like to extend a warm welcome to our webinar number 123, organized by the Andean Health Organization Quality Agreement. This year, we're celebrating 5 years of Horas Conru, a very sensitive and significant anniversary. However, as a reference in Peru, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. Fulfilling the goals and objectives of our countries to strengthen the health of our people. Vaccination against COVID-19 is safe and effective in protecting ourselves and others. The more people who are immunized, the less likely they are to become infected. Make sure you and your family receive the second, third, or fourth dose as appropriate. There's no excuse to comply with the COVID-19 vaccination schedule. Well, today, Thursday, May 26, 2022, we open our virtual doors to discuss a very important topic, the situation of maternal mortality in the Andean region, with the objective of learning about its impact and challenges, exchanging experiences, thus highlighting the importance given to this issue in the Andean region. We invite you to leave us your name, organization, and country from which you are joining us through the comment box in the Facebook Live chat or YouTube Live. In the same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. To access the certificate of attendance this webinar, as usual, you must fill out a short survey and leave your data in the fixed link found in the Facebook or YouTube live chat. This certificate will be sent to you to your email in the next few days. This webinar will be developed with the usual dynamics. We will start with the institutional greeting, then the presentation of our speakers, the active pause, and the space for Q&A. Begin this important day and give the floor to Dr. María Carmen Calle Dávila, Executive Secretary of Horas Conju. Go ahead, Dr. Calle, please. Thank you so much, Gloria. Thank you all. Continuing the cycle of webinars that we started in May 2020, in the third year of the pandemic generated by SARS-CoV-2. We continue to address issues related to health systems and their efforts to ensure access to reproductive health services, gradually recovering 50% of the services that were interrupted during previous years, according to figures from the United Nations Population Fund. As we are all well aware, the causes of maternal mortality are multiple. The most common in the region being hemorrhage, pregnancy-induced hypertension, sepsis, and other direct and indirect causes. At present, the most vulnerable women continue to have difficulties in accessing reproductive health services, such as contraceptive methods, pregnancy, difficult birth, due to the lack of prenatal and postnatal care services and obstetric care. According to the UNFPA report, more than 500 women and girls die every day in emergency situations due to complications from pregnancy and childbirth. In addition, women are more likely to have an unintended pregnancy when they have fewer options and less power. And this is related with gender inequality, lower socioeconomic development, and higher maternal mortality rates. This situation is exacerbated by poverty, lower levels of education and employment, and exposure to violence. To change this situation, among others, it is necessary have public policies that contribute to universal access to maternal health and sexual and reproductive health. Implement evidence-based policies and programs, allocate resources appropriately, involve citizen participation, improve the quality of healthcare services with a focus on rights and equity, as well as the training of health personnel and professional midwives. And finally, improve information and surveillance systems and act on the social determinants of health. In order to address this issue and learn about the current situation of maternal mortality and the challenges to be faced, the Andean Health Organization, Hipólito Unanue Agreement, the Horas Conju, has scheduled this webinar. We welcome Dr. Alma Virginia Camacho, Regional Technical Advisor on Sexual and Reproductive Health, Regional Office for Latin America and the Caribbean of the United Nations Population Fund, Dr. Bremen de Mucio, Regional Advisor on Maternal Health, Latin American Center of Perinatology and Women's and Reproductive Health of the Pan American Health Organization, World Health Organization, and Dr. Alfonso Viacorta, member of the Reproductive Health Office of the Ministry of Health. Welcome you this webinar. I would like to take a brief license. Please give me a few more minutes. This is to acknowledgement that the Andean Health Organization we make to Alma Virginia Camacho. Leaving a position is a very special moment in our lives. For this reason, we do not want to miss this special moment for our dear Vicky Camacho, a renowned physician with gynecologist obstetrician master in public health from Johns Hopkins University, with a wide international experience in topics of women's and adolescent health issues. Vicky is not only an excellent person, but also a great professional, recognized for her values and ethics as the core of her personal and professional life, as well as for her scientific excellence, leaving a legacy in national and regional policies, regulations, and guidelines on maternal, sexual, and reproductive health, maternal mortality reduction, professional midwifery, prevention of adolescent pregnancy, contraception, and technical assistance to countries, documents that she helped to build, as well as in the research carried out, the results of which were and are scientific evidence, contributing greatly to decision-making in the countries where she has worked. At this point, I would not like to mention and thank you for the unconditional support provided to Horas Conju through the Andean Committee on Comprehensive Health for Adolescents, which accompanied since 2011, highlighting the implementation of the diagnosis of the situations of adolescents in the Andean region, the development of the Andean policy on sexual and reproductive health in adolescents, and the Andean Plan for Prevention and Reduction of Adolescent Pregnancy, among many others. Thank you, Vicky, for always joining us in the technical meetings, the webinars to which we have invited you. But above all, thank you for the long days of work in the meetings with the Andean Committee, for the perseverance, time, and dedication that you gave us during these 11 years of work with our institution. We are sure that you will continue to support us and that this is not a farewell, but a stop to breathe and continue walking together. I want you to know that some members of the Andean Committee over the years have joined us at this moment. So I please ask you to start your videos. In Vicky, we summarize the 3 E's that we search as professional excellence, engagement, commitment, and ethics. Thank you so much, dear Vicky, for the time with us. You will soon receive in person this note that we have prepared for you from our institution. Thank you very much.
Queremos, Vicky. Mucho.
No se te escucha, Gloria.
Gracias, Vicky.
Thank you, Vicky. After this greeting, I will introduce myself. I'm Gloria Lagos, Manager of Strategic Lines and International Cooperation of Horas Conyo, and I will be in charge of moderating this webinar. At this moment, I feel obliged to add my thanks to our dear Vicky, who, as Dr. Calle pointed out, has been accompanying the Andean Committee on Comprehensive Adolescent Health in 2020, but with whom we have been friends for over 20 years. Thank you, dear Vicky, for your friendship, sacrificing your birthdays and vacations and participate with us in the technical meetings of the Andean Committee. Thank you for being next to us. Thank you for so much, but above all, for your commitment and work. Thank you, thank you, thank you. Well, after this preamble, we welcome Dr. Virginia Camacho. I'm not going to introduce her because Dr. Calle has already introduced her and her work. So, Dr. Calle, please, Dr. Camacho, you have the floor. Dr. Camacho, you have the space. You have the floor. I got very emotional here. Go ahead, Vicky, please. Thank you so much. Actually, I'm deeply touched by your comments and seeing my faces of my colleagues and friends. I remember the efforts of the countries where I've been working with the best of myself. So I think that your words that Mari Carmen has mentioned in this introduction been beautiful. And actually, I think that as a team, we have faced many things in these 11 years, and we're here, and we continue here. And the important thing is what you live in. Personally, to close this chapter of my life makes me happy. I openly say it because been 25 years of effort in international health, and I think it's time to have young people come in to take over these efforts and work in the different countries. But certainly, I hope to continue being close to you at a personal level as well as in the work if required. So thank you very much. And well, now I have a new stage, and part of it I would like to dedicate it to my family who have sacrificed so much for during these years, especially my husband and my grandchild. So my Santi, yes. So I would like to thank you once again, and I love all of you. Thank you, Vicky. And now let's go and start our webinar. Vicky, you have the floor. Thank you so much. Well, I thought it was going to be Bremen, but that's okay. I think we're both aligned for today's
Yo voy a
presentations.
iniciar
I
la
will, I will
presentación sobre
start my
ya que
presentation on perinatal
cuando Gloria me pidió el
mortality.
título
When Gloria
de
asked
la
me for
presentación, yo la
a
verdad es que pensé mucho
presentation, actually, I thought, give it a
en cuál
long
va a ser el
thought
contenido
to
de esta
what's going to be the
presentación
content
y
of this
cuáles iban a ser los
presentation
aportes
and what will be the
para
contributions
este conversatorio
for
sobre la
this
mortalidad materna en nuestra región y
meeting
especialmente
about
en Bolivia.
maternal mortality in our
Bueno,
Andean
Bremen va a
region.
hablar un poco de la
And Bremen will talk
epidemiología y
about
la
the
situación
epidemiology and the
de
situation
la morbilidad y la mortalidad materna
of
en la
morbid
región y
mortality
también
of mothers in our
el
region,
impacto y el
and
efecto
also about the
directo e indirecto de
post
la pandemia
indirect and
en la
direct
mortalidad materna.
effect of
Y
the
yo creo
pandemic
que
on
me
maternal
voy a dedicar
mortality.
más a
And I
dos
will
áreas
focus more in
en el tema de las
some
intervenciones
areas of
y algunos análisis y
interventions and
reflexiones
some
sobre
analysis
cuáles
and
son los
insights
desafíos
about what are
que
the
tenemos en la reducción
perennial
de la
challenges
mortalidad
that we have in
en
reducing
general.
maternal mortality
Como ustedes decían,
that
desde que inició
continue. And as you mentioned,
mi
since
vida
I
profesional,
started my
me ha
professional work,
marcado, digamos,
maternal mortality has
eh,
marked my efforts.
y quiero hoy hacer un
And
homenaje
today
al
I would
doctor
like to pay
Héctor Melo de
homage
la
to
Universidad de
Hector
Chile,
Melo from the University
profesor
of
y jefe del
Chile,
departamento
my
de
professor and head of
ginecología
the
y
Department of
obstetricia.
Gynecology and
Cuando
Obstetrics.
yo terminaba mi
When I
entrenamiento,
was completing my
él me dijo,
training in GOY,
vas a
OB,
regresar
so
a
he's
Bolivia.
asked me, are you going back
Bueno,
to
si tú
Bolivia?
te dedicas a la
Well,
mortalidad materna y
if you
sobre la
don't work
mortalidad
in maternal
materna,
mortality and
no
reduce
pasaste
it
por
in
el
that
classroom.
country, you didn't spend time
El
in my
profesor
classroom.
Melo,
Professor Melo,
recuerdo que
I
la primera
remember
clase
that the first
del entrenamiento
lecture
era
on
obstetricia
training
basada en
on
mortalidad materna para todos los
GYOB
que
was
éramos
maternal
estábamos
mortality
entrenando.
to all of
Entonces,
trainees.
digo desafíos perennes
So I mentioned
en nuestra
perennial
mortalidad y
challenges
hay
in
una
this
serie de
presentation
líneas que
because there's a
continúan
number of
siendo
lines
desafíos para
that
nuestra
continue
región
being a
en mayor o
challenge
menor
to
grado
our
y que
region
nos
to a
han
greater or lesser
condicionado
degree,
esta
and
semana
unfortunately have
con la pandemia
exacerbated
del COVID.
due to the
Voy a
COVID-19
empezar con la
pandemic. And I will
historia
start
de
with the
Cecilia.
story of
Cecilia
Cecilia.
una
Cecilia
historia real
is a
en base a
true story
un estudio que
based
publicó
on the study
CIDES de La Paz, Bolivia, en el año
published from La Paz,
2017,
Bolivia
que
in
visibiliza mucho
2017,
porque es un
published by
estudio
CIDES.
cualitativo de la mortalidad
I invite you
materna
to
en
read
Bolivia
this paper
y que
because
fue
it's a
dirigido
qualitative
por
study on
mujeres
maternal
y fue
mortality called
coordinado por Marcos Paz
Women in the
en el
Wind, published
2017.
by Paz in
Y hay
2017.
algo
And something
que digamos que esta historia tiene, es que
that
es una
this
historia
story tells us,
que ocurrió hace unos años
this
atrás, pero además
happened a
es
few
una
years
historia
ago,
cuya
but it's also a
determinante de la
story
muerte materna se
whose the
mantiene
determinants of maternal death
como
are
clave, digamos,
maintained as
cuando
key
nosotros analizamos los
when we
factores contribuyentes y
analyze the
determinantes de la
contributing and
mortalidad en la
determinant
región
factors of maternal
el día
mortality
de
in
hoy.
our region
Y
today.
algunos aspectos que coloqué en
And
negrita,
some
¿no?
aspects that I have
Una mujer
highlighted in
que
bold.
tenía dos hijos
A
y que
woman that
por
had two
especificidad
children with a third pregnancy
sufría de violencia
who
doméstica.
suffered from domestic
Una
violence.
mujer del
A
área
woman
rural,
from the rural area
pero que no hizo nunca un control
but
prenatal
had
hasta
never
el embarazo
prenatal control
por el cual
until the
ella nació,
pregnancy
¿no?
where
Pero
she
no acudía al centro de salud
died. But she
porque
didn't come to the
por
health
costumbre,
center
digamos, y por una cuestión cultural,
because
no
of a
se daba.
cultural thing.
Sin
She
embargo,
didn't consider
en su
it
último embarazo sí
necessary.
quería
But
ir
in
al
this
centro
last
prenatal
pregnancy,
recién en el cuarto
Cecilia
mes
went to
y
prenatal
en un
care
centro
starting on the
específico
fourth
donde
month
había una
in
licenciada
a center where
que
there was a
podía
nurse
asesorarse de ella como
practitioner
médico.
and she trusts her.
Otra cuestión que me llamó la
Another
atención
thing that
de esto y que
called
es una de las
my
determinantes
attention
más
and one of
importantes
the most
de
important determinants of
esta
maternal death
historia es que
from this
es la
story
pobreza, ¿sí?
is
Ella
poverty.
vivía
She lived
en una habitación
in
de
a
adobe
precarious one-room dwelling of
con un techo
adobe
de
and
paja y
stone
barro, sin
walls with a
ventanas, y en el piso
thatch and mat
donde
roof,
vivía
no
tendía a
windows and
llover y
dirt
a caer
floor,
granizo.
where she lay down on a
Sus cinco
sheepskin
largas
to
horas de
sleep on.
trabajo de
And after
parto,
5 long
Cecilia solo
labor
recibió la
hours,
ayuda de su
she
esposo.
only received the
Tuvo
help
una
from her
infancia
husband.
saludable
She
y hermosa,
finally gave birth to a
pero no
healthy
logró
baby,
expulsar la
but she was
placenta
not
y
able
empezó
to
a
expel
sangrar.
the placenta and began to bleed profusely.
Había ahí un promotor de salud,
There
un
was a
médico
health
tradicional,
promoter,
pero que
a
había sido
traditional physician
capacitado
that had
y
been
se enteró de
trained
la situación, quiso
who learned
ayudar
about the
y el
situation
esposo
and
lo
wanted to
impidió
help, but
entrar
the
a la
husband
casa.
prevented him from
El
entering the
promotor
house.
hizo todo lo
The health promoter did all effort possible to have a physician visit this home, but unfortunately that was not possible. When he went back home, Cecilia's children told him that she had passed away. So based on Cecilia's story, we'll start my presentation by talking about some issues that we believe relevant with regards to the framework for maternal health. This referential framework provides us two important things. First, the sustainability and sustainability approach. And we talk about maternal mortality. We, from an global interagency group, we generated a document which is the World Strategy for Women Health and Child Health. It has three approaches: survive, prosper, and transform. This region has still pending things with surviving because we looked at Cecilia's story. But there's also, I could say, that several countries are in the possibility of prospering and others in transforming. So our strategy is focused on the protection of women, children, and adolescents who are key stakeholders of the society in order to make progress in the Sustainable Development Agenda, 2030 Agenda, where there are three objectives that are key if we want to understand and approach maternal mortality in accelerated. One is 3, 5, gender equality, and 10, reduction of inequality. And here, remember that there's a number of indicators of human development, gender inequality, and among the human development indicator, reproductive health is in the core on building this indicator together with empowerment and participation in the labor market, the women who measure gender inequality. And when we look at the health dimensions in the gender inequality index, we see two major indicators in this health dimension. One is the maternal mortality ratio and adolescent birth rate. These two indicators make up this index through a female reproductive health index and contributes directly and together with the female empowerment index towards the building of the gender inequality index. And I show this because we've seen this in Cecilia's story. There's some gender inequalities that were expressed in her death in conditions related to labor. In the interagency group, where with Bremen, we share our work in the executive committee. Last year, we launched this interagency strategic consensus for maternal mortality reduction. And in this context, in Bremen, we'll show you some data, some robust data that we've been able to collect. In the strategic orientation, the first point has to do with context and call of action. And there are two elements that I would like to mention. First is there was a staggering of maternal mortality before the pandemic, stagnation of maternal mortality, and we've gone 10 years setback due to the COVID-19. And
resume, digamos, esta llamada a la acción. Hay varios puntos.
This slide that summarizes the call to action. There's several issues here related to the objectives of sustainable development and the index of gender inequality and human development. First, we are today in a position to call the governments and strategic partners to reposition the reduction of preventable maternal mortality in Latin America and Caribbean political agenda. A priority. It has no longer a priority now in some countries due to different reasons, but we know that when we start acting maternal mortality or we stop intervening or investing, maternal mortality has a setback. So the progress is diluted, and this is something extremely important. The other is the allocation of resources. We had long discussions on investment, and we're doing some studies about investment in key interventions for maternal mortality. We have completed this in Paraguay, and we're going to be able, and we told the government of Paraguay, how much do you need to invest to make the cost-effective interventions reach universally to all women and adolescents. We know that maternal mortality is preventable, but we also seen an increase of indirect causes due to the cases associated with 19, and the abortion is still a significant public health problem. So our emphasis today is to give importance to social and economic determinants of maternal mortality, as we see in Cecilia's story. And of course, the urgent actions to recover coverage and access to essential of reproductive health services and focus on the local, on the territory, where this is a multi-level approach that we need to have at the level of the countries where people live, where we have to work. So our consensus has a number of recommendations. I've shared this many times, but this is going to be useful as as a guidance mechanisms during the presentation. Among the recommendations, we have the public policies to achieve universal coverage. If there's no access in universal coverage in maternal health and sexual reproductive health care, there's not going to be universal access. This is the key indicators of sustainable development goals. The other day, I was reading a report about an event in Indonesia last April. Dr. Silver Smith from WHO said something that we need to close the gap between policy and science, because that gap is a matter of life and death in relation to maternal mortality. And here is where we have one of the major challenges in our region. Here is where we see join the interventions based on evidence and are cost effective and that will reach all women, universally speaking, and those who, especially those who live in greater conditions of vulnerabilities. This needs to be translated for words with concrete interventions throughout the. The issue has to do with the health systems, and these are the recommendations for which we have worked and are working in our interagency working group that has to do with rights and equity, leaving no one behind. It's not a slogan of the 2030 agenda. It's a reality in our countries because internal inequalities in the countries are profound and have exacerbated the pandemic. I was looking to an issue that I'm going to share with you. I told Bremen the maternal care to do some analysis and how this is translated in a key intervention for the process of recovery and transition during the pandemic. And the health personnel, investment in education and training. These years of pandemic, not much access to continuous education. I was thinking about the Aesthetic Congress in Honduras, and they were telling us how difficult had been to maintain the process of continuous education with direct obstetric causes of maternal death and the role of professional midwives. You know that I do believe that professional midwives, matronas or obstetras or obstetrices, however they called, are a core human resource to guarantee a positive experience during pregnancy, delivery, and contraception, but also in order to have a model that's focused on women's care in surveillance to maternal uh, death, and with no data, we would not be able to make progress in terms of maternal death. And we've seen that the surveillance systems in some cases have weakened during the recent years with the pandemic. The contraception is one of the areas in our strategic approach because promoting and prevention is a key issue for unintended pregnancy. And we see more and more unintentional pregnancy, especially in girls under the age of 15. We had a webinar with PAHO and UNICEF where Maria Carmen participated in the issue of preventing and reducing pregnancy in girls under the age of 15. You know that these girls under the age of 15 have a greater risk to die and to complicate during pregnancy and delivery. The comprehensive response to unsafe abortion is something still pending in this region. In our proposal, we speak about the access to interruption according to each country's legal framework, but this should go together with a comprehensive approach of dignified and respectful care and post-abortion counseling, care, and contraception. Within the contraception, post-abortion, and the dignified and respectful care are still a challenge, perennial challenge in this region. And of course, the great contribution during the pandemic in women who live in migration and humanitarian crisis, and how can we ensure the adoption of public policies and protection systems are current in each one of each country. So COVID and maternal mortality, some issues for our recommendations have to do three things that we need to acknowledge, and apparently we haven't been able at some point to guarantee women a positive experience. And due to this experience in the different COVID waves, especially the second wave in our region, we saw that women stopped attending the health services because of the poor experience during the first wave. So we need to recognize three things, and something that Gloria mentioned at the beginning as a key message when we started this webinar, which was to prioritize vaccination in pregnancies, recognize the pregnant women at high risk when they face COVID, and acknowledge the indirect effect that COVID has in other direct and indirect causes of maternal mortality. So among the critical priorities when we do this analysis of challenges and of addressing maternal mortality through our document of recommendation by GTR, there's some points that I think that would like to transmit today, and I will finish my intervention with this. First, the universal sexual and reproductive health access and coverage is a perennial challenge with the determinants that we already mentioned, better understanding of the factors contributing to maternal death. We need to do a better analysis of the data that we have on maternal mortality, the efforts to restore and strengthen essential quality and sexual and reproductive health services, focus on right and respectful maternal care as a key condition for recovery of quality maternal and reproductive health services that respond to the needs of women, and to focus on leaving no one behind. So at this moment, we are carrying a study on maternal mortality to learn the contributing and determinant factors of maternal in 4 countries in the region: Chile, Ecuador, Colombia, and Dominican Republic. And here I would like to add that once we have the recommendations ready, we will be able to share with the rest of the countries of the region. We would like to encourage each country to have a better understanding what are those contributing and determinant factors from the perspective of decision makers and the families of members of women who die in health providers. This is essential to have a roadmap for recovery, to acknowledge that we have a syndemia, and based on the studies that CLAD had done on maternal mortality, on the analysis of more than 400 cases of maternal death, and reading and reviewing information. Once again, there's 5 issues that are common to all the studies: indigenous origin, Afro-descendant, ethnic minorities, and migrants, and undocumented has been and is an issue. The rather population that have the greater impact of these determinants: obesity, pre-pregnancy comorbidities, maternal age, and living conditions of greater vulnerability. These are common patterns in the recently published studies. So it's not a syndemia. It is a syndemia where gender and gender inequality and comorbidities play a great role. Reproductive rights have been affected by this crisis. Yes, the effect on each one of these essential interventions for reproductive health, but these rights have been vulnerated in this time. And this is an analysis of a study, and we expect that from the starting from the study that we are completing and we are collecting data that we have on the care process and what have been the changes in the health services. And it's a 3 axes: the availability of service, the content, and quality of care, and adaptations to care. And here we see what happened in terms of availability alone to reduce routine cares or visits. During labor, more women had their delivery in their homes, and postnatal care, there was an important reduction of the visit. In the content and quality of care, there was a reduction or banning of visitors to hospital admissions. And once again, we see elective cesarean sections performed in most of women with COVID. And Bremen, perhaps we're going to show some data for our region. But were the adaptations? We had adaptations in the model of care. We have adaptations in reduction of waiting rooms, social distancing in clinics and hospitals. In labor, there was a dedicated cesarean section room for COVID-19 patients, and we need to review this. Also, in postnatal or postpartum care, there were some changes with digital health, telemedicine, etc., but there was a significant reduction in operating hours or interaction of outpatient care. This is a result of this study with Serman Ode. And here I would like to highlight what were the direct and indirect effects in relation to the positive experience of women and how this affected their reproductive rights. So the need to look respectful maternal care, promote a positive experience during the prenatal period and delivery as a core in the recovery process. So during COVID, this is a study made by a group of midwives called Respectful Midwifery Care during the COVID-19. But there's something that is important in this effort. We need to recognize that women form a vulnerable group, pregnant and women, but not homogeneous. But they have the fundamental human rights to dignity and respectful midwifery care that safeguards both physical and mental health of the mother and the newborn. So there is a need of a further follow-up and interventions. It is critical to provide women-centered care, establish good communication with mothers, and offer emotional support and stress management in these times. And the report of midwives last year, this report urges that we, we need to have contribute universal health coverage and meet the sustainable development goals. And here they play an important role because we know that midwives save lives. So these are some of the results of some very simple studies that we did at the beginning of the pandemic in order to understand in the scope of professional midwives what were the opportunities and challenges. Here we have a summary of what the midwives responded in this survey that we did together with the University of Chile. And something that caught my attention as opportunities, they saw visibilizing the role, but also as a threat, they view that they were not being considered as a first line team during the pandemic. And we had a number of delays. So we need to address interventions to improve the experience during pregnancy, during delivery, and reproductive health in order to contribute to reduction of maternal mortality, but with a comprehensive approach using as a spearhead the respectful maternal care. And this is how the primary healthcare teams may contribute using the conceptual framework of first delay, second delay, and third delay related to the critical path of maternal death. So how we can change those poor experiences that women suffer and have lived during decades as negative experiences during pregnancy, during delivery, and during the exercise of their reproductive rights. And that can be changed with clear interventions and basic interventions that go through a team providing health education, acknowledging that women and adolescents are autonomous beings that can make decisions, education in reproductive health to decide and not obey. This is key where the primary healthcare teams and throughout the health system, we can contribute to promote the decrease the fear of women to look for support for contraception and the preconceptional visits, gestation, delivery, postpartum, and the third delay to have a team that has the competence for the timely diagnosis and referral, delivering good provision of care and positive experience. And finally, we need to use the lessons learned from the good practices during the pandemic. We did this work with 22 good practices. There are many others. I'm just putting this as an example. We need to sit down and review these lessons learned in order to set the basis of a roadmap for recovery. But this recovery helps us that women can have access to comprehensive health services based on the rights and part of the fundamental of universal health. We know the pandemic exacerbated these inequalities, and therefore the recovery has to be seen as an opportunity to change the structures that perpetuate them. And this structural change, and this is a call that we're doing, where the Congress women members say that we have to make sure that human rights and gender equality are the core approaches to the process of recovery for sexual health and reproductive health. Cecilia's story is that. Let's not repeat the story. We have a major opportunity to change these challenges that are no longer perennial challenges in the care. Thank you so much. Thank you, Vicky. We acknowledge that women have more chance of having an unintentional pregnancy when they have less options and less power. And that is related with the profound gender inequality with a less socioeconomic development and higher mortality, maternal mortality rates, eh, and with vulnerabilities, conditions, poverty, at lower levels of education and employment and exposure to violence. We will continue now and to reverse that process with the pandemic. In order to have the significant reductions in maternal mortality, we need, as Dr. Camacho mentioned, to put emphasis in social determinants as well, in having public policies about these topics to strengthen the information system with appropriate records without forgetting the need to have budget for their implementations. Let's remember what Dr. Cayo always tells us, with no budget, there's no rights. And this is always true. Well, we will welcome Dr. Bremen de Musi, who is a regional advisor in maternal health in the PAHO WHO Latin America Center for Perinatology, Women's Health and Reproductive Health, LAB SMR. He's a physician, specialist in obstetrics and gynecology, as well as in health services administration. He also has a master's degree in family and community health and a PhD in perinatology. He worked for more than 15 years as a professor at the School of Medicine of the University of the Republic of Uruguay in the chairs of obstetrics and gynecology and social and preventive medicine, occupying positions as assistant professor and associate professor. For 7 years, he was respectively director of the maternal child, women, and child and reproductive health programs in the Ministry of Public Health of Uruguay. He has twice obtained the National Prize of Medicine awarded by the National Academy of Medicine and has published more than 120 papers on topics related to his areas of expertise. He's an honorary member of the Nicaraguan Society of Obstetrics and Gynecology. Welcome, Dr. De Mucio. You have the floor. Go ahead, please. Thank you, Gloria. Hello, colleagues. How are you? We're going to start my presentation sharing with you some data that I know you all know, but I would like to emphasize those data that apparently will be old, because what I'm showing you is this publication, Trends in Maternal Mortality, which is the estimations done by the interagency group from the United Nations to estimate maternal mortality figures, because as you know, the ratio of the maternal mortality ratio, which we can mention is one important indicator for human development, is having some trouble. And the problem is that I always say the same. The mortality, the MMR is no longer a sanitary indicator and is a political indicator now. Unfortunately, many people, to instead of considering the real magnitude of maternal mortality, they lie and they present results that are not respond to reality. With that clarification, I would like to show you this map, what I have added. The MMR at the level of the world in 2017, published in 2019, was 211. That time, in the north part of the Americas, in Canada and Estados Unidos, was 18 per 100,000. In Latin America region and the Caribbean was 74 per 100,000. Let's see how this maternal mortality ratio has changed with this source of information. And from the year 2000 to 2017, maternal mortality was dropping on a regular basis, not at the rate that you would like, but it was coming down. However, you can see that this is one of the ways that we have to look at maternal mortality more frequently, even when we talk about national average, because as we all know, the national average hide all those inequalities that we should do better analysis by age, by work, job availability, education, migrants or not, occupation levels. So if we are looking at what we see with maternal mortality, you're going to find that to the left, we have the region. In the second column, it talks about the lower levels of MMR for a confidence interval of 80%. In the mid column, shows us the MMR with point estimate, followed by the highest level of maternal mortality. And the last column is what I ask you to, was telling you to need to focus, because here we're talking about the lifetime risk of maternal death. Why I want to put these three columns here, especially for those countries that manage the information. In some cases, you can find a mistake, but other countries in America, especially in the Andean area, do not count their an adequate count of maternal mortality, and they follow surveys. If the survey for the world will give us 243, this estimation could be in the highest level, and is well done, although the point estimate can be 211 and the lower level 199. When we use estimation, we need to work in that range of 100 or 120 to 180. So we say 100 to 180, and mortality will fall in the middle. But that is when we are using estimate and not working with numbers counted of maternal death. We saw in the world 211, then we have 74 for Latin America. Now let's look at what maternal mortality, or what used to happen in 2019 with data from 2017 in the ORAS control countries. You see the maternal mortality ratio. What is 13 deaths per 100,000 live births in Chile? Of each 4,600 births, the chance of having one death is 1 in 4,600. On the other side, we have Bolivia. So the death in Bolivia has a greater chance to die in Bolivia because that ratio is of 1 in 220. So every 220 mothers who deliver, one will die just by that chance. An important way to look at this, because you see the limited difference between Ecuador and Colombia in terms of the chance of dying, 640 for Ecuador and 630 for Colombia. However, when you see the MMR point estimate, Ecuador seems to be much smaller than the Colombia. Well, now let's move to the next one, and what we see, if we take what is in blue, the Latin America, as a central estimate, we see that Chile and Ecuador are below those values, while Colombia, Peru, Venezuela, and Bolivia are in red because they are above those values. Now let's see at the same graph that I showed at the beginning, but with the estimates made by the group by the group from Pajo. You know that in the Americas region, the countries agreed to have a reduction of maternal mortality of per 100,000 for 2030. To remember this is to say that the impact of the region is 30 for 2030. However, there's an intermediate point in 2025 where we establish that maternal mortality should be in year 2025 around 35. Now look at the right, this indicator performance in our region. If we see this estimate with data from 2017 that were published in 2019, the rate of reduction of maternal death, this slope is not going to get even closer to what the countries have committed to, which is 35 per 100,000, because we're starting from a baseline that in 2015 and has changed very little. So just by looking at the published data, the estimate document that we saw at the beginning, the mean annual reduction that we need to comply with our goal to reduce as a region 5.29% the MMR per year. Something that has almost been missed in a region. At present, we had a mean rate of 1.41. So 3 times less what we need, and this was before the pandemic. In priority countries, the ones below Belize, Bolivia, which are Guatemala, Honduras, Nicaragua, Paraguay, and Suriname, we find that that reduction was a little higher, 1.81, but it is precisely those countries where it should be greater to compensate, because as you can see, a country as Canada, Chile, Uruguay, or the US, who have maternal mortality quite low, it is very difficult to reduce maternal mortality by 2/3 from 2010 to 2030, when maternal mortality is very small or very low. So considering this, we have a major problem before the pandemic. So now let's see what happened at this moment during the pandemic. Vicky mentioned this study. This is a study of what we call a multi-country collaborative database with, at the beginning, we had several countries from the Andean area. Actually, we had 5 countries, but we need to use data from only 4: Bolivia, Ecuador, Peru, and Colombia. So 4 countries participated in this process. Thank the international advisory from PAJO that at that time was in Colombia, Ivy Talavera, who helped us, and now she's here in Peru at this very moment. I was telling you that we published data from 8 countries, of which 4 were from the Andean area. Unfortunately, we had data from 9 countries. One fifth country that I'm not going to mention from the Andean area, when we did the search of maternal death by COVID, we found 55 maternal deaths. However, the country reported a much smaller number, and they said that if we want to use the data, we need to include that much smaller data from the real one. So I show this, we can understand, especially those who have some doubt of what I mentioned before. With MMR, you can lie. This is a clear example. You cannot use the real data from a country because a country reports less mortality than the one they had, almost 3 to 4 times less maternal death of what we found. These things are very concerning, because to the extent that we cannot change that mentality at the government levels, it is difficult solve the problems that we have. Here, I show you things of my region. In particular, more than 60% of pregnant women had COVID in the third trimester, and therefore the need to vaccinate them before the third trimester. If they are scared because of an effect that the vaccine may have in the first trimester, we can make sure to provide them a few weeks after the first trimester to guarantee greater safety, although no adverse effect has demonstrated so far with children or mothers with this vaccine, especially the messenger RNA vaccines. That is not the case with vaccines that have to do with virus carriers like the AstraZeneca that demonstrate at some point that it could or may be a potential cause to increase thrombosis that you know that in pregnancy this is a special phenomenon. The other thing that's relevant in this case, that more than 90% of women who we enroll in this study in died had an multi-organ failure when they were admitted to the health care. And what is catastrophic is that 1 out of 3 women who required access to intensive care unit in the 8 countries that we study, only one had access to intensive care. What puts a high risk population to a lack of access to special care with the risk, the additional risk that you know that COVID in pregnant women produces severe symptoms and gets even worse in short time. Let's see what we see with with a look on the long term.
Lo de México. Tenía
This is
también
what we saw in the US and Mexico. I don't have any specific information from the Andean region. You see in the US, you have the 3 peaks. And in fact, maternal mortality was higher in the first 2 peaks in 2020, when dropping in 2021, but they had this third wave in August with an increase on mortality and then decrease. And when Omicron started in 2021, maternal deaths start falling down dramatically. But in this period, the vaccine coverage in the US was extremely high among pregnant women. That's not the case as our countries. In the case of Mexico, we have a different behavior because in the first, despite Mexico had many maternal deaths in the first month of 2020, the major peak was in December of 2020 with a second wave and a third wave between June and July produced a peak in deaths, and we have a smaller peak by Omicron of maternal deaths, but many hospitalizations, like you see in the black line showing that deaths were lower. That means that in Mexico, the vaccination worked and services were no longer saturated as they were before. And this is one of the most important interventions, as Vicky mentioned. Having services that can receive women with adequate equipment and human resources, and also encourage vaccination to reduce complications. This is current data. We don't have the data from 2021, but we do have from 2020. This is data from Ecuador. It's a time sequence. And I would like you to pay special attention to the green line, because that green line corresponds to direct obstetric causes that clearly increase. You can tell me, yes, they did increase, but there was also an increase of direct obstetric causes. Yes, in some cases. In the indirect, COVID had greater weight, but also the interruption of services had to do with that increase of maternal death to direct obstetric cause. But what happened to late maternal death? They had a mild decrease. And why did that happen? Because in Ecuador they were increasing, but because many women who had some sequelae died before they had a sequelae due to COVID complications. And in this slide, you can see indirect causes of maternal death due to respiratory infections, previous years. You see 1 to 1 are due to influenza, but here in 2020 is 25, and those 25, of course, were deaths due to COVID. Similar situation for Colombia, except that maternal death, he corrects himself, the late death, that I don't have them. Let's look at the indirect causes. You see how the indirect causes increase significantly, as well as direct also increase significantly by the same reasons. In Colombia, you can see that maternal death, indirect cause, viral usually involved, like influenza and other respiratory infections, were 5, 2, 2, 2, 4, and we came up to 77. Similar situation for Chile. We have preliminary data from Chile. You see the data for 2021 that showed us that maternal mortality, the general mortality rate, came back to the figures that we have in 2019, or it's going to be pretty close to the pre-pandemic era. However, in 2020, the increase was large, both for indirect causes in green as well as direct causes in yellow. Chile, maternal death of indirect cause by viral infection was 7 in 2020 and 11 in 2021. However, in 2021, despite that they had more cases of COVID,
Y eso tiene mucho que ver.
maternal mortality starts to decrease, and that had to do with the response from services. Now, how has this impacted the region? We in PAHO, with the data that we have, countries that have shared, we were able to see that the maternal mortality ratio at the end of 2021 shows that maternal mortality ratio has moved to what we had in 2014, 2013. So maternal mortality has gone back 5 or 9 or 10 years. We expect that at least of what we saw in Chile and we are seeing in other countries, that we will start with a quick recovery in each country that will lead us to position in the previous figures. Our colleagues from Ecuador have shared data that show maternal death has gone backwards, similar to what they had in 2019. But this is not enough. That we saw in the first slides that the serious problem is that maternal death in our region has stopped. Vicky mentioned a number of necessary interventions. I will add to what Vicky said, a specific concept that our governments, or most of them, have forgotten of maternal mortality, and they don't have forgotten because they're evil. They have forgotten because they have prioritized other things. In the countries of America, except Guyana, in the preparation of this biannual work done by PAHO, only one country left as a priority issue to maternal mortality. And it makes sense that other countries change their priorities, such as non-transmissible diseases, and among them cancer, degenerative diseases that are a real problem. But what we need to warn is that if we cannot make our governments prioritize this issue, and as Vicky mentioned and Gloria mentioned, if they don't allocate the necessary resources, it is very likely that we are going to evolve more slowly and we will not reach the goal established. What we are really concerned is what this means. Women didn't have access to the rights that they had, in particular to have a good quality care and universal access to health services. I think that I use a little more time, but I apologize and I'll stay here longer. Gloria, thank you so much. Thank you, Dr. De Mucio. Very clear, very important presentation. And yes, I would like to thank you to stay in the room so we can share some questions from the audience. We require to look at maternal mortality ratio quite honestly without being afraid of the data that we have in our countries. If that's not the case, there are two things that we'll be able to do. The results and projections presented by Dr. De Mucio show us a major challenge. We need to generate information, evidence that allow us to make the adequate decisions to contribute in complying with the goal of reducing maternal deaths. We need to improve the information and surveillance systems in the region. And as we mentioned before, we require to act on social determinants of health without forgetting prevention and the timely care of COVID-19. We need to follow our vaccination schedules and be alert and work for everyone. We would like to greet all those connected to with us from the Andean country, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, as well as Uruguay, Paraguay, Argentina, Cuba, Mexico, Brazil, and Guatemala. To the officials of the health institutions and the public and private institutions who are joining us, thank you so much. Continuing with the agenda, we would like to welcome Dr. Alfonso Viacorta. He's a physician specialist in gynecology and obstetrics with a master's degree in public health, PhD studies in public health, assistant physician at San Bartolome's Hospital for 14 years. He is the former head of the maternal perinatal program, former director of the family planning program, a former director of the Office of Quality in Health, former national coordinator of the sexual and reproductive health strategy from the Ministry of Health in Peru. He has also worked in several international cooperation projects with CARE Peru as maternal and child specialist with the Project 2000 from USAID, with Pathfinder International Maternal Health and Child Specialist, the Catalyst Project, with HPI as maternal and child specialist in the Health Policy Initiative projects, and as team leader of the maternal and child health and reproductive health and family planning quality in health project. He has worked as a consultant for the Ministry of Economy and Finance, the INEI, the National Institute of Statistics and Informatics, in GTZ, this German Development Cooperation, and CESTAS, with the Center for Health Education and Appropriate Technology from Italy. Welcome, Dr. Viacorta. It's a pleasure to have you. And now you have the floor. Please go ahead. Thank you, Gloria. Before starting, I would like to greet Dr. Virginia Camacho, who is going to a new stage in her life. We wish her well, and to continue with that capacity that you have. Congratulations, Virginia. So we're going to start my presentation by sharing my screen. Thank you for the invitation. Let's see. I'm going to share the screen.
Muy bien. Finales del 2019. At
the end of 2019, we spent Christmas and New Year, and we sat in 2020. And during the month of February or March, we started the COVID-19 pandemic in our country. And this list that I show you, it's a copy from for all the Andean region countries. Something similar happened in other countries. Limitations in access to health services, disorganization of obstetric networks, late evaluation of pregnant, prenatal care was discontinued, the use of contraceptive was also discontinued, there was a delay in detection of obstetric risks, the closure of ambulatory services, 30% of the health staff had to be sent home either because they had comorbidity or could easily got infected with COVID and several of them died. The close of ambulatory services, reaction in health professional, there was a rotation of staff, interruption of the supply chain, saturation of the ICU and emergency service. And in the population, there was a restriction to movement, confinement. There was a fear of people to go to health centers. There was an increase in family violence, an increase of anxiety, depression. At the beginning, there was misinformation about these issues. There was a delay in the management of complications. There was a decrease in home visits. There was a decrease in all the process that we had for the delivery plan, a delay in referral due for obstetric emergency, prioritization of expenditure to COVID-19 care, limitations to have access to COVID-19 vaccine. We didn't have the sufficient amount of vaccines. This is something that we saw in most of the countries of South America. What happened in Peru? If we see here that bleeding and the direct causes, maternal deaths, were greater than indirect causes, but in 2021, and I would like to emphasize, in indirect causes by COVID-19, we got up to 40.9% of death produced by COVID, which increased the number of deaths by indirect cause over the number of deaths due to direct causes in the first semester of 2021. At the beginning of the second semester, the vaccination of pregnant women started. This mortality, COVID is reduced from 40.9 to 8.4 in the second semester. It was a remarkable effect how the vaccination had the important effect first with patients over the greater than 28 weeks and then 14 weeks, and then the pregnant women in general, but there was a marked decrease with regards to the number of deaths. And for 2022, we had very few deaths to COVID in pregnant women, and all of them were in unvaccinated. So this chart shows us how the indirect mortality went above the direct cause, but that was due to the COVID-19. We see the maternal death by epidemiological week that each week that the first peak of 2019 in 2020, he corrects himself, the peak was of 18 maternal deaths at the week 18 in that first wave. The second wave came and it was worse because at the week 9, we had the highest peak of 22 maternal deaths on that week. We got the vaccine. There was a radical decrease of the number of deaths with a maximum peak at week 7 in 2022 of 12 deaths. This shows us the importance that we had in this process of care the vaccination of
sumamente
pregnant
importante en nuestro
women,
país.
extremely important for our
El número
country.
de muerte
If
materna
we see the number of
muy bien
maternal deaths
durante los años reduciendo paulatinamente
by
año
a
con año
gradual reduction,
y justamente para el año
and precisely for
2019 llegamos al
2019,
menor número de muertes
we had the
maternas en los
lowest
últimos
level
200
of
años.
maternal deaths of the last 20
Pasó
years in
esa
our
epidemia
country.
COVID
We
y
started the
reprimimos se
COVID-19 problem,
incrementa la
and there
mortalidad
was an
materna
increase
nuevamente
in
por
maternal
Omicron
deaths
y hasta el momento en
2020 and
2022,
even higher in
en 2021. Para el
2021. For
a la
2022,
semana 19,
at week
estamos hablando
19,
más o menos
we're
hasta la
talking
semana
about
el 14 de mayo de este año,
May 14.
nuestra mortalidad materna
Our
está
maternal
por lo menos
mortality
muy por debajo
is
del año
very well
pasado,
below the last year,
prácticamente más del 50% menos
more than
que el año
50%
pasado por la
less
misma
than the
semana de
previous
este año.
year for that same week
Y
19,
12% menos
and
que
12%
el año que
lower
menos muertes tuvimos,
than the year that
que fue
we
el año
had less deaths, that
2019.
was 2019.
12% menos al momento de
12%
la
less
actualidad,
until
lo
the
cual
present
nos
time,
permite abrigar la
which
esperanza de
allow us
que este
to
año
be
pudiéramos
hopeful that
tener,
this year,
esperemos que esto sea así,
and
por
we
el trabajo
expect
que
that this is
ustedes
going
están
to be the
haciendo
case
a
due
nivel
to the
internacional,
intense effort in all
pudiéramos
the
tener
regions,
las cifras de
we
muerte
can have
materna más bajas de los últimos
the
30 años. Y
lowest
esperemos
levels
que
of
sea
maternal
así.
deaths in the last 30 years, and we
Eh,
hope that this is going to
en
be the
este
case.
esquema estamos
What
siguiendo
schedule are we
para
following
poder trabajar los
in order
diferentes
to work
procesos que
with
se
the
ven
different
en el manejo
processes
de
that are seen
la
in the
enfermedad gestantes y la
management
muerte
of
materna?
women and reducing
En parte
mortality?
estamos tomando como
We are
base la
taking
cadena causal
as
laboral,
the
donde tenemos tres
causal
eslabones que
chain
son tres eslabones.
where we have three
El
links.
primer eslabón es que para
The
que la
first
mujer
is
muera de
the
muerte
women
materna tiene que estar
die.
gestante.
Well, first of all, she
Eso
needs to be
es
pregnant,
obvio
and this is
y nos
obvious.
permite tener en cuenta
Allow us to consider
algunos elementos claves sobre
some
nuestro
key
equilibrio,
elements of our
en las cuales
key
trabajamos
strategies
fuertemente.
where we are strongly
Específicamente,
working.
en los métodos anticonceptivos postparto,
Family contraception,
la
postpartum,
atención integral de las víctimas de
the
violencia sexual.
comprehensive care of
Todo eso
women
gracias a
of
Dios lo tenemos bastante
sexual
fortalecido en la
violence,
pandemia
which is
sexual,
something
y
that
la
we've seen
planificación
increase
familiar.
in
Estos
preconception
aspectos nos
care.
permiten, por un
These
lado,
aspects allow us,
asegurarnos
on one hand,
de que
that
los que
one
están
pregnant
en una
woman
respuesta apropiada
who
para iniciar
is
una gestación
not
puede utilizar un
inadequate,
método de planificación familiar para
is not
retrasar
inadequate
o
condition
postergar
to use a
sus
contraceptive method
relaciones hasta
to
poder
delay
ayudarla
her
a resolver
pregnancy
sus
until
problemas
we
y
can
a
help
tener
her
mejor salud.
solve her problems and
Se ha
improve
podido
her
trabajar
health.
también a través de incentivos
Also, through
económicos
economic
para el
incentives
fomento de la
to
anticoncepción
improve
post-evento
post-obstetric
se
event
ha comenzado
contraception,
a hacer todos los
and we
aspectos
started to
normativos
consider
para
all the
asegurar que una
regulatory
víctima de violencia sexual,
aspects
incluyendo
to
riesgos
the
de violencia,
comprehensive care of women
tenga
who
todos los
suffer
atendidos hospitalarios
sexual
y acceso a
violence.
tratamiento de salud. El segundo eslabón de la
The
cadena
second link of
es
this chain has
justamente
to
la
do
gestante.
that once this
Una vez que la paciente
pregnant
gesta,
patient,
durante su proceso, para
during
poder
the
hallar la
process,
muerte, tiene que desarrollar algún problema de salud.
she has to
¿Qué
develop some
estrategias
health
tenemos que manejar para esto? La atención
problem. What
prenatal,
strategies? Well,
el
prenatal
seguimiento de
care,
esas pacientes que están
following
en
these
edad temprana,
pregnant women,
el parto institucional
the
y la
institutional
planificación
delivery,
oportuna, que son
and
dos
the
puntos
timely
sumamente
referral,
importantes que hemos
which are
tenido
important
que
topics
plantear
that
durante todo
we
nuestro proceso.
have seen during this
La atención
process.
prenatal, obviamente, tiene que ser una
Natal
atención
care,
prenatal con calidad,
of course, has to be a good
una
quality
cobertura
care
muy alta,
and
pero
have a
queremos
high
estar
coverage,
seguros que esa
but we need
atención
to
sea
make
con
sure that
calidad.
that care
Y
is
la
quality.
tercera,
And
el
the
tercer
third
eslabón de la
link,
cadena es que una vez que la paciente
that
gesta
once
y
the
su
patient is
complicación,
pregnant and has a
esa
complication,
complicación
this
pueda ser
complication
tratada de
can
forma
be
apropiada,
treated
adecuada
on
y
a
correcta.
timely and adequate
Si
basis
no se
and
da esto,
efficiently. If this doesn't
la muerte
occur,
materna es el paso que sigue.
then a death
Y
is
para
going to be
esto
present. And for
estamos
that,
trabajando fuertemente en
we're
dos aspectos
working
claves.
in two
El
key,
manejo
like
adecuado y oportuno de la
adequate
emergencia,
and timely
para
management
lo
of
cual
the
se está
emergency.
capacitando
And we
iniciando
are
un proceso bastante fuerte a partir
going through a
de
process of
diciembre del año
training
pasado hasta el
that
momento,
started
de
December of
capacitar
last
a
year,
médicos,
and
obstetras,
to train
enfermeras en primer nivel de
physicians,
atención,
process
en segundo
obstetrics in
nivel
the
de
first
atención
level
primaria,
of care,
y luego ver el
and
tema
then
de morbilidad materna extrema, que
consider
es una importancia
extreme
superlativa
mortality,
al tener morbilidad
maternal
materna extrema porque
extreme
es el paso
morbidity,
previo a la muerte
because
y donde
that's the
tenemos que intervenir de la forma
step
más ágil
previous
posible.
to death, and we need to be
Y por
very
otro lado,
efficient in
para
our
poder realizar este
intervention.
tipo de
And on the other
intervenciones,
side, to
conocer
make
ya
this
de
type of
antemano cuál es nuestra
interventions,
capacidad
to know
resolutiva como
what is our resolution capability in our institution, and have clear information of what we have, what we don't have, what we need, what we're lacking, what about our resources and procedures. So based on this process, we can see in this first link, the women is pregnant, provide you some specific data. And here we see that the fertility global rate is being reducing continuously. And in 2021, we have 2 compared to 2014 where we were in 2.5, but there's always this difference of the rural area where we have a 2.7 rate compared to the urban rate 1.8. And of course, if we see regions, especially in regions of the jungle where those rates are high. The use of family planning methods in women, the information from Andes, the national survey, I'm having trouble here sharing.
Estamos viendo la imagen, la primera imagen, la lámina de inicio.
We're looking at the first slide. So from this Andes, this national survey show us that in the last 5 years, the use of family planning methods is 78%, and with modern methods, we have 57%, which is quite a challenge to improve this and make patients can have the knowledge and guidance so they can adopt some modern method, improve this process because they will give us better outcome. On the other hand, in the second link, here we have key issues like prenatal care, pregnancy follow-up, and timely referral. And we have this information from the health and examination survey in women 15 to 45, 49 years, if they got prenatal care. And this number, although there's been a critical problem in the year 2021, but in the previous 5 years, this is maintained in a very high level. And institutional delivery, according to this survey, in the last 5 years, we need to maintain this level in coming years after the pandemic. On the other hand, we have provided importance for timely referral. For that, we have an information model system that allow us to have national institutions interconnected, and that have to do in order to do a timely referral of patients, a WhatsApp system that allows us to have the comprehensive health insurance and the ambulance emergencies services and su salud health to the heads of the major hospitals in the country, to the head of the Ministry of Health, including the vice ministers. And this allows us to have expedite information. So with the agreements that we have with the armed forces, we have planes, helicopters, and ambulances to do timely referral. This has allowed us to save many lives in recent years. We're restarting this quite strongly. Last February, we back with this schedule, and these are allowing us to help many women who are in extreme risk. On the other hand, we have the vaccination, and we need to continue with this. On the other hand, in the third link of the chain,
Estamos trabajando.
Perdón, Alfonso, por favor,
Sí.
cuídense los micrófonos, manténganlos apagados, por favor. Gracias. Adelante, doctor Villacorta.
En este tercer elemento
in
que es
this
la
third element, which
debe ser
is
tratada
the
rápidamente,
complication that needs to be
porque
adequately
si no, la
treated,
paciente puede
otherwise the
tener
patient can
Estamos
die.
trabajando, como dijimos,
We are
mucho en temas
working
de morbilidad
in
extrema, y el
extreme maternal morbidity, and this is the management of emergency. We have two regulations for epidemiological surveillance of extreme maternal morbidity that is done by the National Center of Epidemiology of the ministry, and on the other hand, with other regulatory for the follow-up of extreme maternal mortality. So we have a system that allows us that once the patient is admitted to a hospital with this extreme morbidity, we have the daily information of how this patient is evolving, so we can intervene if needed, either by telemedicine or referral, or require blood or blood products, or the presence of a specialist in a hospital, or have dialysis. So they can have support so the patient can get best chances of getting treated by this extreme case. And for that, we are using the WHO criteria, which are quite severe criteria, but allow us to have an limited case of severe cases to which we can do an efficacious treatment. And on the other hand, we have this system that allow us to analyze the resources that each health institution has. The last evaluation was in September in 2021 in pandemic, but we were able that of those close to 8,800 health institutions, 7,807 facilities present their information, and this was evaluated in first level as Fund P 7,200, the basic ones 457, the FONE1 with the district level facilities, and FONE 2, the hospital levels at the province or national level, and the intensive level for the maternal and child national institute. This is evaluated every year. We still have a major work to do because the figures need to get up to 90% are still low. This is one of the areas where we need to work intensively. Very well, so in conclusions, we're facing a world pandemic that has surprised us, overwhelmed us. We were in a critical process, and this has made things even worse. We recognize the pregnant woman as a risk population in terms of infections. The vaccination is making progress and generates protection for severe forms of disease and reduces mortality. And this has been demonstrated with the data we have. There are many social determinant factors that we need to work on that have to do with access to health services. It has to do with primary health care. There was an increase in maternal mortality because there was a reduction in the offer services by the severity of the individual health situation. There was a delay in trans referrals, the services were saturated, but this starting to change. We're going back. The entire process of hospital care. We need to continue watching the quality of service in response to this causal chain to cover critical conditions. The greater challenge to maintain our services, being able to respond to the demand with an appropriate level of care and quality. The team effort is extremely important. Physicians, obstetrics, physicians, staff, nurses related to this type of care. And we need to establish good coordinations between institutions to prevent complications to get worse and to generate greater problems, and we can solve the complications. As I mentioned at the beginning, we hope that this year, based on the detailed information week by week, we can this year have the smallest number of maternal deaths of the last 30 years. And this is where we would like to go. Thank you very much for your attention. Thank you again. Thank you, Dr. Viacorta. Very interesting participation. The reality of our countries is no different to the rest of the region, as you pointed out. We need to consider that the maternal death causes, either direct or indirect, require greater follow-up, not only of the process and actions, but also of women who receive care to demonstrate the quality of the service as well as to give the response. Whatever the vulnerability situation is, the strengthening of the staff who provide services through training is of very utmost importance in order to achieve the expected percentage in Peru, as you pointed out. I'm sure it will be that case. Thank you for the efforts being carried out at the central level towards the regions. Thank you to the three speakers. Now, I'm going to ask you to start your videos, Vicky, Bremen, Alfonso, because we have some questions. We're not going to be able to respond all of them. However, we're going to consider them for coming seminars. But I'm going to give you some of the questions that we have received through channels. I will start with Dr. Vicky Camacho. How can we strengthen the controls from the first trimester in order to detect the alarm signs and do timely care? Sorry, Gloria, I didn't hear. Could you please repeat the question? Yes, of course. How can we strengthen our control from the first trimester in order to detect alarm signs and do a timely care of the patient? I think that we need a campaign from the Ministry of Health at the community level with community networks. Make sure that women go to the prenatal control since very early in their pregnancy. We need to promote health from the health services, but also with off-site activities where the primary healthcare equipment can look for pregnant women and study them at their home. This is very important. And the third element has to do with improving knowledge of health providers as well as community health providers about the importance of prenatal care and the best way to detect alarm signs. So there are activities from the health services, from the education activities at the community and family individual level, and there are also the work with community efforts with the grassroots groups that are organized to discuss about the importance of the early detection of alarm and signs linked, of course, to a referral and contra-referral system in health. Thank you. Thank you very much, Dr. Camacho. Now, Dr. Bremen de Murcio, what is the vaccination rate in general scheme of pregnant women during the first semester? What is the importance? I don't have data for the first question. What is the vaccination rate in pregnant women? And of course, it varies from country to country. The importance of vaccination, of course, you know that last October, the CDC showed a study that was confirmed later on by everyone, not the CDC of Peru, but the CDC from the US. They showed a study where they demonstrated that by comparing pregnant women with non-pregnant women with different ethnic and age, pregnant women had higher risk of being hospitalized with COVID, admittance to the ICU, and death if they were compared with other women. So because this is a risk population, since last October, the CDC in the US prioritized them, and many countries prioritize them too, even before the international organization took measures. Indeed, in fact, PAHO last year, during the advisory technical group for vaccines from PAHO, recommended vaccination of pregnant women due to the high risk, even before WHO, that a few weeks ago ended up recommending vaccination to pregnant women as a risk group per se, without thinking in another type of comorbidity that they may have. Thank you, Dr. De Murcio. We had a question for Dr. Viacorta. Do we have that age
Sí, sí, por supuesto,
group?
tenemos
We have
información
information of MMR by age?
Se ha reducido un poco
Yes,
la
there's been a
natalidad en adolescentes,
decrease in
pero
maternal death for
todavía
adolescents,
siempre entre
but it's always between 25 and 35 years of age,
mayor muerte materna.
the largest number of maternal deaths.
Semana a semana por
And we have this information week by week by age. Thank you, Dr. Viacorta. Doctora Camacho, do you consider that we are going to get new threats due to the global critical situation? How can we prioritize maternal health? Yes, of course. I think that the threats and sanitary emergency are going to continue. And this is something that we anticipated for a couple of decades, not just from today. With the arrival of H1N1 and then Ebola, we knew that pregnant women had a higher risk, and also MERS, of getting ill and dying due to a respiratory virus. So the best way is to be prepared. And this is something that countries, when they prepare against future sanitary emergency, should place in the center of these preparation plans pregnant women and children. This is a key issue. This is something that from the Spanish flu, we know that these are the populations at risk. So we need to include them in the preparedness plans against sanitary emergencies. No matter what emergency we are dealing with, we need to consider pregnant women and have in place an organizational health system considering this population. Thank you very much, Dr. Camacho. Dr. De Murcio. The PAHO or Lancet study shows that 50% of the cases of maternal death had obesity. Obesity is still a risk for vaccinated pregnant women. What policies or strategies are required to improve food habits and physical activity in pregnant women? Go ahead, Dr. De Murcio. Thank you, a very good question. those deaths were collected before the vaccination, the general vaccination of pregnant women started. These are pregnant women who died in 2020 and part of 2021, and not all of them were vaccinated, but regardless of that, obesity is still being a significant comorbidity for vaccinated and non-vaccinated women, pregnant women. So we need to avoid that pandemic of obesity in Latin America, and the measures that the person who did that question asked proposes. This is not easy. We need many interactions. Only one is not going to be enough. First, because you know that the food industry also conspires for people to eat. With food that are high in fat or carbohydrates. So against that, there are many interventions to be done. And as Vicky said, also there needs to have a national campaign, not only direct advisory of a midwife or a gynecologist in an obstetric visit. Campaign way above the clinics, clinicians in particular. This is an intervention that has to be taken from the public health, not individual care. Thank you, Dr. De Mucio. Dr. Viacorta, what strategies are you using to increase access of pregnant women from indigenous people, migrants, and from rural communities to prenatal control?
Sí. Importante la pregunta.
Very
Es
important
un
question.
trabajo bastante intensivo
We're doing an
de
intensive
promoción de la salud
effort through health
para poder
promotion in order
conectar a
to
las poblaciones indígenas a
get
través de las
closer to
comunidades
indigenous
hacia
populations
servicios de
through
salud.
health promoters and take
O
them to
llevar
health services,
a
or
los equipos de los
to
servicios de
take
salud hacia las
the
comunidades
health
porque hay
crews
ese intercambio
or
de,
teams to the
tanto
communities,
de
because
ida como de
that
vuelta.
needs to be going
Es un
both
trabajo
ways.
bastante intensivo
There's a very intensive effort done in
tiene
this regard.
programas
We
importantes para
have
migrantes
important programs
al
for
punto
migrants,
que el paciente
to the
migrante
point that the migrant patient,
por el hecho de ser migrante ya tiene
just by being a migrant,
su seguro integral de salud
has
y
an
ser migrante es un seguro
comprehensive
integral
health
migratorio. Por lo tanto, recibe la atención
insurance,
en los
so they
hospitales
get
de seguro
care
gratuita en cualquier parte del
free
mundo.
of charge in any part of the country. Thank you. As I mentioned, we are not able to respond all the questions, but we will consider them to define the topics for the next webinars. And we thank you very much for your interest and participation in this event. To close this space of Q&A, I would like to ask the speakers that in 1 minute, give us a final message, a recommendation, or lessons learned about the challenges on this topic. We will start in the same order of the presentation, Dr. Camacho, Dr. Bremen, and Dr. Viacorta. My dear Vicky, you go first. My message is that remember that the indicator of MMR is very sensitive because it's an indicator that has a numerator that doesn't correspond to a denominator. That's on one hand. So any increase in maternal death is going to increase this MMR ratio, and any decrease in the number of births is going to have an effect on the indicator. However, today, in the 21st century, one maternal death is an excess. So remember, all of us who are members of this community that looks to reduce maternal mortality, as having one maternal death by a preventable cause is something that we need to consider as alarming and an excess. And therefore, we cannot lower the guard with maternal mortality and maternal health. That will be my most important message. And remember always that women have rights, and our models of care should respond to women's needs and their adolescent families. Thank you so much, my dear Vicky. Bremen, go ahead. Well, my message goes exactly to the final part of what Vicky mentioned and has to do with the role that we as health agents to reposition maternal health in the political agenda of the countries of our region. If we don't achieve that, the results are going to drop because we had the peak until we get a new pandemic, which is something very likely because there's a large number of cases of influenza at this moment. Did you know that influenza also kills women and children? So they're not always getting the vaccine. So start talking about maternal health in the agenda. And I will even dare to add a second message that for those diseases that are controlled with vaccines, especially in particular COVID and influenza, continue to insist because pregnant women need to be vaccinated against those infections. Thank you, dear Bremen. And Alfonso, go ahead. Well, basically, ask you to break each of the links of this chain of causality of maternal health. So breaking the first link is that one who's not pregnant, go to see the family planning doctor, and she wants to become pregnant, do preconceptional control, so you're in optimal conditions to start your pregnancy. On the other hand, if you are pregnant, start prenatal control early because you can identify any problem, and that prenatal care ended up in an institutional delivery. Try to avoid home delivery until we have something more adequate in terms of that, and in terms of services to improve the resolution capacity, improve how they treat the humanitarian treatment when they care for pregnant women. This is going to help the pregnant women that they don't see the facility as something to which they're going to spend the entire day or morning and they're going to capitulate at home. Like they see it as a place where they're going to get the best possible care in the best possible way and with respect, respecting their rights. Thank you so much, Alfonso. Well, just to thank you again and to all the attendees that week after week are with us, also to thank the Horas Conjunto team and all who participate in this activity has been possible thanks to the commitment with Latin American and Andean integration. Of course, I would like to insist, thankful to excellent speakers, Virginia Camacho, Bremen de Mucio, and Alfonso Viacorta. Vicky, I'm not going to close without saying thank you. Thank you for so much. Thank you for all, for everything. I'm sure we're going to continue working together this road of fighting for public health and the rights of women, children, and adolescents. Thank you, Vicky. Thank you, thank you, thank you. A big hand for Vicky. I invite you to the next webinar on June 2, A Healthy Planet for the Well-Being of Everyone, our responsibility, our opportunity. Thank you so much. Bye-bye.